Delusion is the only thing that we study. So what is a delusion? It is a false fixed belief held with extraordinary conviction, and it is out of keeping with a person's religious, cultural and educational background, right? So that is why belief of God or belief of ghost is not as such a delusion, right? Now coming to the different types of delusion. Different types of delusion can be seen in psychotic disorders like schizophrenia, depression with psychotic symptoms, mania with psychotic symptoms, etc. Whereas delusion alone can occur without the presence of any other psychotic symptom, that is called as delusional disorder. So in that delusional disorder, each type of delusion will be mentioned as a subtype. So delusion of persecution means they say that someone is out to harm me, kill me or shame me. Persecution means somebody is trying to harm you, right? So delusion of persecution, you have a false fixed belief that some people are out there to kill you, out there to harm you, or they are trying to shame you. They are following you, they are spying on you, they are tapping on your mobile phones, your computer, they are watching you through cameras, CCTVs held everywhere, right? So this is called as delusion of persecution. So when it comes in a delusional disorder, we say delusional disorder persecutory subtype, right? Delusion of reference, people keep referring to me. So what, when you walk into a room and somebody is talking and laughing there, right? And you feel that they are talking about you. They are laughing by making fun of you, right? So everything that is happening in the world is in reference to me. See, they might be just looking at some comedy and laughing. They might be talking about something else and laughing. But that doesn't strike in your brain. You have a very strong belief. It is a false belief, but a strong belief that they are talking about you. So that is delusion of reference. Delusion of love. So if I love somebody, is it a delusion? No, not necessarily. So when we love somebody or when we have a feelings, we say, I love that person, right? I love you. I love that person. Whereas in delusion of love, the person will say that that person is in love with me, right? The other person is in love with me, and that other person might not even know about this person, right? The other person might be a celebrity. The other person might be somebody of a very higher status. The other person might not even know the existence of this particular person, but they say, no, they are in love with me. Did you see the other day they went in this car and they smiled through the window? So it knows it was because I was standing behind and they smiled at me. It's a random thing, right? Did you see Nayanthara in that movie? She was smiling so well. She was saying these dialogues. She said that because she loves me. Can you say? That is delusion of love. Delusion of nihilism, nihilistic delusion, right? It occurs very commonly with depression, severe depression. They say that I am a dead person. I am an empty vessel. There is no blood in my body. There is no organs. It's just an empty box. So they believe that very strongly. That is delusion of nihilism. Capgras syndrome. Capgras syndrome is a delusion of misidentification. Capgras syndrome and Frigoli syndrome are misidentification syndromes. Okay. So in delusional misidentification syndromes, Capgras syndrome, what you say is, I know this person is very close to me, but this is not that person, right? So close person is replaced by a stranger. So I know this is my mother, she looks like my mother, she sounds like my mother, she's even dressed like my mother, but she is not my mother. She is somebody else dressed like my mother. So a close person, C for C, close person is replaced by a stranger, right? Whereas in Frigoli syndrome, it is the opposite. A stranger is replaced by a known person. It is not necessarily a close person, in a known person, right? So what happens in Frigoli syndrome? Like, you are somebody, random person standing in a bus stop, but you are not a random person. You look like a random person, but you are actually my boss, disguised as a random person and standing before me to persecute me or harm me or kill me or etc. Right? So that is called as delusion of misidentification syndromes, Capgras syndrome, close person replaced by a stranger, and Fregoli syndrome, a stranger being replaced by a known person. Delusion of grandiosity, seen very commonly in mania. I am God, I am very famous, I am very powerful, I have special powers. This person would be just an auto rickshaw driver or a beggar or somebody who's living off the streets, who's doing daily labor. Okay, but they will say, I have 100 acres of land, I am the one who's advising Modi ji, I have special powers, I made the rain that came yesterday, I can stop the rain if I think, I have special powers. So all of this comes under delusion of grandiosity, very commonly seen in schizophrenia and also in mania. The delusion of grandiosity very commonly seen in schizophrenia and mania. Delusional memory. So everybody has a BCG scar, right? So BCG scar would be there. We might have some chickenpox marks. We might have some scars from our childhood. Now, persons with delusion, they will say that this scar was by this persecutor who injected a camera or injected something to track me or used the scar to inject something to kill me. So this scar is an actual thing. It's an older memory. Now they are giving a delusional meaning to it. So this is called as delusional memory, right? Delusional perception. Again, in delusional memory, the memory is true, right? The scar is true, but they are giving a delusional meaning to it. Same way in delusional perception, the perception is true. They will see something. Let's say they see a red car or a white bike, right? Whatever. And they will associate that with a delusion. I saw that red car, which means the person is going to kill me. It has no relation, but they give a delusional meaning, right? So these are the types of delusions. Delusion of persecution, when somebody is out there to kill me. Delusion of reference, people are talking in reference to me. Delusion of love, that person is in love with me, but that person doesn't even have an idea of who I am, right? Nihilism, they say that I am an empty vessel, I am dead, I have no organs, right? Capgras syndrome, close person replaced by a stranger. You look like my mother, but you are actually a stranger dressed as my mother. Fregoli syndrome, stranger replaced by a known person. You look like a stranger, but you are actually my boss trying to haunt me. Right? Grandiosity, actually they are not having anything, but they claim bigger powers, bigger status, bigger financial requirements. Delusional memory, memory is true, they have a delusional meaning to it. Example, BCG scar used by aliens to control me. Delusional perception, there is a true perception, but a delusional meaning to it. Right? Now coming to hallucinations. So what is hallucinations? Hallucination is a disorder of perception where there is no actual stimuli, right? So it occurs in all 5 sense organs, right? Eyes, nose, ears, tongue and touch can occur. So when there is a stimulus and you perceive that sense, that is true perception. When there is no stimulus and you perceive it, that is called as hallucination. So something different than hallucination is illusion. Illusion is just a misinterpretation of a real stimuli, right? I look at a rope and I think it is a snake, right? I look at branches in the tree and I think it is a, what to say, it is a crowded place full of animals, something like that, right? I look at a box of sweets and I think it has certain bees coming out of it, something like that, right? There is something real and in the light shadow it looks like something else, right? That is illusion. Whereas there is nothing at all, but I am seeing things, that is hallucination. So perception without a stimulus in the outer objective space, uncontrollable by the patient, right? So if there is this pen and I am seeing this pen, is it controllable by me? If this pen is there, I will see the pen, right? So that is true perception, right? Just like that, the hallucination also believes that there is this pen, but actually the stimulus is not there. There, I can see this pen. So when it is like a true perception, I cannot control it. right? Even I'm imagining it, I can control it. Whereas true hallucination, we cannot control it. Only difference is there is no actual stimuli, right? Whereas in pseudo hallucination, there is no stimulus and it occurs in the inner subjective space like our imagination, and hence it is controllable. Right? I feel like I am seeing something. I feel like I am hearing something. Looks like a hallucination, but it is not actually a hallucination. Right? So auditory hallucination, most common type of hallucination, it is seen in schizophrenia. Visual hallucination, it is most commonly seen in delirium and dementia, all neurocognitive disorders. You can see visual hallucination. Tactile hallucination seen in cocaine bugs. Multiple time asked question. Okay. Right. So hallucination is perception without a real stimulus, and it is occurring in the outer objective space. It is not within your brain. It is outside. You cannot control it. You truly feel like you are seeing it, you are hearing it, or you are being touching it. Right? So that is hallucination. Whereas when an object is misrepresented, that is called as illusion. And if you feel like you are hearing, seeing things in your inner subjective space and it is controllable, that is called as pseudo hallucination. Most common type of hallucination is auditory hallucination. Auditory hallucinations are most commonly seen in schizophrenia. Visual hallucination is most commonly seen in neurocognitive disorders, delirium, dementia. In dementia, Lewy body dementia and Parkinson's dementia can have most common visual hallucinations. Tactile hallucinations are seen in cocaine abusers, also called as cocaine bugs, Magnan syndrome. Right. Now coming to certain fancy terms used in psychiatry, they have been asked in questions like match the following type of questions have been asked using these terms. So it is better to get acclimatized with these terms, right? Formication. Formication, another term for cocaine bugs. Another term is Magnan syndrome, right? Formication, Magnan syndrome, cocaine bugs are all same phenomenon where there is tactile hallucination occurring in cocaine abusers. Okay. So because of these tactile hallucinations, there will be lots of scratch marks and wounds and ulcers, right? Next is Corphologia. Corphologia is this picking behavior. They will be picking on the bed sheets, bedspreads, the IV line, etc. That kind of picking behavior seen in neurocognitive disorders like delirium and dementias, right? That is also called as floccillation. Okay, so corphologia and floccillation are the picking behavior seen in most commonly in delirium patients, but also in other organic psychiatric patients, right? Oniroid state is a dream-like state. So it is not like you are completely present, you are not like completely slept, but it is like in a dream-like state, right? Is an old psychological term, but it was asked in a question. Twilight state. So it is like before stupor, right? There is a discontinuity in the consciousness. You are not completely conscious, you are not completely stuporous, you are in between, right? Stupor, right? There is no response at all or very minimal responses. So your mouth is not opening, your muscles are not moving. That is also called as akinetic mutism in psychiatry. So phrenia is the word used to describe thoughts. So oligophrenia, less thoughts. Hyperphrenia, excessive thoughts. Right? Schizophrenia, split thoughts, split mind. Right? So phrenia means thoughts. Paranoia means suspiciousness. Right? So being paranoia, he is having paranoia means it was an older term used for suspiciousness. Gegenhalten phenomenon, also called as paratonia. It's called as passive rigidity. So it is not like it is rigid. You're checking for tremors and rigidity. This is how you check cogwheel rigidity or lead pipe rigidity, right? So it is not actually having that kind of quality, but it is having a candle-like quality, right? That is called as paratonia or passive rigidity. Michigan and Mitch-Machen means automatic obedience. So if you are asking a patient to protrude the tongue and you are saying that I am going to prick your tongue with the needle and the patient still obeys you, that is called as automatic obedience. You are trying to lift a patient with one finger. You're just pulling his dress like this and you're trying to lift them. Then still they are getting up. That means it is automatic obedience. So all of this are commonly seen in catatonia. Viberidine giving approximate answers, seen in Ganser syndrome, seen in gangsters and prisoners. Right? So these are certain terms. Once they have asked a few of these terms and their explanations in a match the following type of question. So in this book, the author Jean Dominic Bobby had locked in syndrome. It's a neurological syndrome which you might have studied. So the patient is not able to move any part of the body, but it's still able to understand. So in this case, they were able to move the eyelids alone. Right. So with the blinking of the eyelids and choosing certain letters by blinking yes or no, they wrote this entire book. Right. So it's called as locked in syndrome. Right. Now coming to delirium. Delirium is another term used for acute encephalopathy, right? Encephalopathy, anything to do with the brain system and the consciousness and the orientation is affected, right? But they behave in a psychotic way. They have delusions and hallucinations. Hence, it is coming under the purview of a psychiatrist, right? So, delirium is usually a medical emergency. So, call-overs given in psychiatry, one of the emergency call-overs is for delirium. It has 30% mortality rate and it is the most common organic psychiatric disorder and it is reversible. If identified what is the cause and treated, it is reversible. Right. The important thing is it is acute and it is fluctuating in nature. Right. So, if you are working in an ICU or a medical ward and a person suddenly starts developing delusions or hallucinations, we just discussed delusions and hallucinations. If the person suddenly, acutely, within like 2 hours, within like 1 day, they start developing delusions and hallucinations, you cannot term it as schizophrenia. You have to check if it is delirium. So, it's acute, that acute in onset. Right. And also morning the patient will be having symptoms, afternoon the patient will be okay, evening again they might have symptoms, night again they might be okay. Again it is fluctuating within the day. So that is also a feature of delirium. It occurs very commonly in elderly because of decreased brain volume. In medical and surgical illnesses because of susceptibility to multiple medications and also in substance use disorders. One of the most common terms used for delirium is also ICU psychosis. The cognitive symptoms in delirium are impaired memory, language, and perception. Visual hallucinations are most commonly seen in organic psychiatric disorders like delirium and dementia. That's what we studied. So here visual hallucinations are very common. They will have hallucinations like animals crawling up the wall or they are seeing certain things, etc. Right? Consciousness is impaired, orientation is impaired, attention is impaired. So if these three are impaired, it is almost always delirium. It is not acute psychosis, it is not schizophrenia. Just because delusions and hallucinations are there, if the consciousness orientation is impaired, then it is delirium. There is motor and sleep and emotional disturbances also. It gets worsens in the evening and night. That is called as sundowning phenomena. Right. The most common neurotransmitter involved in delirium is acetylcholine, which is decreased. Anticholinergic drugs precipitate delirium. Anticholinergic drugs, most common example, atropine. So, a lot of drugs precipitate delirium. Any drugs with anticholinergic action can precipitate delirium. The scales used to assess delirium, MMSE, mini mental state examination, which is given here. Okay. It is a rating scale, a quantitative scale to assess organic psychiatric disorders, both delirium and dementia, right? So MMSE can be used, but the most common thing used even by nurses is confusion assessment method. This was a previously asked question. Is there any test for delirium? No. For identifying the cause of delirium, you can do multiple blood investigations, CT brain, MRI brain, whatever cause you suspect, you can do investigations. But one investigation that you can do to confirm delirium is EEG, diffuse slowing of waves. In the diffuse slowing of cortical background activity is seen in the EEG imaging, that is seen in delirium, right? Except in alcohol withdrawal delirium where there is fast activity, right? Treatment is treating the underlying cause, but just like how we give paracetamol as a symptomatic management in fever, here we can give low-dose antipsychotics and low-dose benzodiazepines as a symptomatic management for delirium until the cause is identified and treated. Okay? So delirium is a neurocognitive disorder, acute in onset, fluctuating in nature, also called as ICU psychosis. It has a high mortality rate, hence it has to be identified and treated early because it is reversible in nature. But once delirium comes, there is a higher propensity for getting delirium in similar circumstances. So when a person is having a CABG done and there was a delirium, after 3 months, if they have minor electrolyte disturbances also, delirium can occur. Right? So here the cognition might be impaired, there is consciousness that is impaired, orientation is impaired, motor and sleep disturbances can also occur, perceptual disturbances like visual hallucinations and delusions can also occur. It's also called a sound downing phenomenon. Acetylcholine is decreased, that is a neurotransmitter. So anticholinergic drugs can precipitate delirium. And it is assessed using CAM and MMSE scales. EEG shows diffuse cortical background activity except in alcohol withdrawal delirium where there is increased activity, and also treatment is treating the underlying cause, right? So symptomatically we can give low-dose antipsychotics and benzodiazepines, right? Now coming to dementia. So dementia is another organic psychiatric disorder, right? It's a cognitive impairment. It is not just memory disturbances. It is cognitive impairment involving all of these symptoms. So disturbance in social cognition, attention, memory and learning, perceptual motor, language, and executive function. SAMPLE, sample, social cognition, attention, memory and learning, P for perceptual motor, L for language, and E for executive function. So in dementia, multiple classifications are there. Cortical and subcortical dementia is one such classification. In cortical dementia, examples are Alzheimer's, frontotemporal, and Creutzfeldt-Jakob disease. Frontotemporal dementia is also called as Pick's disease. Subcortical dementias, Parkinson's, vascular dementia, Lewy body dementia, and normal pressure hydrocephalus. The reversible causes of dementia are normal pressure hydrocephalus, vitamin B12 deficiency, thyroid tumors, trauma causing subdural hematoma, delirium, depression presenting as dementia, Wernicke's encephalopathy in alcohol dependent individuals, and medication induced dementias. Right. For treatment, we use acetylcholine esterase inhibitors because here also acetylcholine deficiency occurs in the neuronic synapses. Right. So certain drugs that we can use are rivastigmine, donepezil, memantine, aducanumab, lecanemab, etc. Right, rivastigmine and donepezil are acetylcholine esterase inhibitors. They are available in oral and transdermal patches. Dementia patients are not always cooperative. They do not even remember you, right? How would they cooperate if you give medications? So transdermal patches have been identified. Right, rivastigmine is used as a daily patch. Donepezil is used as a weekly patch. Aducanumab, lecanemab are monoclonal antibodies targeting the top proteins. Brexpiprazole is FDA approved to treat behavioral problems in persons with Alzheimer's dementia. Okay. Right. These are the important pointers in dementia. So this test given in the image is a clock drawing test. Clock drawing test, which can be used to assess the neuropsychological status. Here they show visuospatial errors, hemi-neglect, disorganization, clumsiness, etc. So all of these executive functions can be tested using this test. Lewy body dementia, yes, you can call it as mixed type, but if there is an option of subcortical dementia and worse comes to worse, you have to choose subcortical more than cortical, right? But yes, it can be mixed type. Okay, right. Now coming to alcohol use disorders. So alcohol use disorders, we need to know everything in alcohol use disorders. This is a very, very, very important topic. Sometimes 2 questions are asked from alcohol use disorders in the same exam itself. But every year one question is asked, at least one question is asked from substance use disorders, and it is most commonly alcohol use disorders, right? So what is the symptoms when alcohol intoxication occurs? There is a recent intake with problem behavior. There is slurred speech, incoordination, unsteady gait, nystagmus, impaired attention, impaired memory, stupor, and coma. Sometimes, right? The legal limit for driving is less than 30 milligram per deciliter of blood alcohol concentration, right? So in the 6 to 8 hours of withdrawal, you get tremors. In the 12 to 24 hours, you get seizures, generalized tonic-clonic seizures, which are also called as rum fits. In 48 to 72 hours, you get delirium tremens. In delirium tremens, the EEG shows fast activity. Other delirium, the EEG shows cortical slowing. Wernicke's encephalopathy, very, 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 very important question. Wernicke's encephalopathy is acute in nature, and when there is a thiamine deficiency, it occurs. B1 or thiamine is deficient, right? Right. So what happens? The symptoms are GOA, global confusion, ophthalmoplegia, and ataxia. You can remember, people go to Goa, drink a lot, and come with Goa-like symptoms: global confusion, ophthalmoplegia, and ataxia. Right. It is reversible in nature. You have to give high doses of thiamine, IV, and then orally. Right. If you don't reverse it, it will lead to Korsakoff syndrome. That is why before giving any glucose containing IV fluid to alcohol dependent individuals or alcohol intoxicated individuals, we have to always give thiamine IV and then give dextrose or D5 or whatever. Right. Korsakoff syndrome, it is only partially reversible. Here there is anterograde amnesia and confabulation. Right. So what happens in detoxification? When the person stops drinking, in order to prevent the withdrawal symptoms like seizures, delirium tremens, etc., we give the medicine called as benzodiazepine, which substitutes alcohol in the brain, right? So that is detoxification. During withdrawal, if there is a seizure, or that is called rum fits or delirium tremens, if any of these comes, what is the treatment of choice? Benzodiazepine. After detoxification, maintenance phase, what is the treatment? Anti-craving agents like acamprosate and naltrexone, and the aversive agent called as disulfiram, which inhibits aldehyde dehydrogenase, right? Okay, so in alcohol, you should know intoxication symptoms, you should know withdrawal symptoms, you should know drug of choice for withdrawal symptoms, you should know what is Wernicke's encephalopathy, what is Korsakoff syndrome, what is the treatment for it, and they ask again and again all mixture of questions in the same area. It is easy to answer, you just have to know it, right? And what are the maintenance agents, what are the anti-craving agents we use in alcohol, right? Other questions they have asked in recent exams are the stages of change in persons with not just alcohol, stages of change or motivations in all substance use disorders, and also in any motivation, right? Even for studying for NEET-PG also the stages of changes applies. This was asked in a substance use point of view, right? Here it was given by Prochaska and De Clemente, right? The stages are pre-contemplation, contemplation, preparation, action, and maintenance. If maintenance does not happen, what happens? Relapse happens. So, for example, a person who is drinking is not even thinking about quitting, that is pre-contemplation. Thinking about quitting is contemplation, right? Going to an alcohol de-addiction center or a psychiatrist, or doing some measures to stop drinking, that is preparation. Actually quitting drinking is action. If the action states maintains, it is maintenance, and in maintenance if there is a reversal or a relapse or a lapse of drinking happens, it is relapse. So this is a cyclic. The same happens in smoking. You're not at all thinking of quitting is pre-contemplation, thinking of quitting is contemplation. Taking actions, trying to take preparations to quit, like visiting a doctor, etc., is preparation. Actually quitting is action, and maintaining is maintenance of that quitting period, right? What else can be asked in alcohol? Newer questions, if they want to ask, they can ask what are the rating scales that we can use. Audit is one rating scale which we can use to identify alcohol dependence. CAGE is one questionnaire which is used for screening, right? Audit is for alcohol dependence, CAGE is for screening for alcohol dependence, right? SIVA, Clinical Institute Withdrawal Assessment Scale, is used for withdrawal assessment. So if a person is coming with tremors, it will be less. If the person is coming with nausea, vomiting, tremors, delirium tremens, seizures, then the SIVA score will be higher. So depending upon the score, we can increase the dosage of the benzodiazepine that we give, right? So these are the alcohol related questions. Now coming to cocaine, the next most commonly asked question other than alcohol is cocaine in substance use disorders. And the most common question asked is cocaine bugs. It's like repeated like 3 or 4 times, right? So it is a stimulant, it is a CNS stimulant. So there is increased heart rate, pulse rate, increased arrhythmia and seizures. Right. When we are using cocaine, we use it in the upper lip, the buccal mucosa and the nasal mucosa gets affected. Hence, there is nasal septal perforation and black tongue. Cocaine is a stimulant, heroin is an opioid, right? Both of this have opposite actions. In a particular proportion, they give a particular high that is called as speedballs, right? So, how do we treat it? We use alpha blockers, phentolamine, benzodiazepines, verapamil, etc. to counteract the symptoms. So these are the scratch marks seen in tactile hallucinations, cocaine bugs, magnet phenomenon of cocaine users. Okay. Now coming to the next substance, opioid. So this is a CNS depressant. Right? Heroin, morphine, pethidine are all opioids. The street names are smack or brown sugar. So how they use the opioid in a particular fashion, that is called as chasing the dragon. It is a CNS depressant and there is decreased respiratory rate, pinpoint pupils, bradycardia, and sometimes it can result in coma. The treatment for opioid overdose is IV naloxone. The symptoms of withdrawal happens in a flu-like symptoms. There is pain, diarrhea, lacrimation, sweating, piloerection. There is oozing of all orifices, lacrimation, nasal, rhinorrhea, salivation, and sweating, and diarrhea, etc., etc. There is oozing out all orifices. And since there is pinpoint pupil in the intoxication, there is mydriasis in the withdrawal symptoms, and there is excessive yawning. Cows is the clinical opiate withdrawal scale used to assess the withdrawal symptoms of opioid dependence individuals. Treatment for detoxification, we use methadone, buprenorphine, clonidine, depending upon the individual symptoms. For maintenance, again we use opioid substitution therapy, because the most important problem with opioid abusers, more than the opioids effects, it is the sharing of needles and the usage of contaminated needles, which is the reason for STD, hepatitis B, HIV, etc. So instead of in order to prevent those harmful behaviors, we give them opioids, oral opioids as a substitution. You come to the hospital daily, get this tablet, you will not have the craving for opioids. So opioid substitution therapy has methadone and buprenorphine. Anti-craving agent naltrexone can be also used for opioid withdrawal and opioid maintenance, right? This is clinical opiate withdrawal scale. Okay. Now coming to addiction criteria. So addiction criteria itself was asked as a question once. So they gave few sentences, statements from these, based on these, from 4 statements. Which of the following is true regarding addiction? Right? So all 4 statements were correct in that question, but that is how the question is asked. Right? So what is the dependence criteria? The mnemonic that you can use is withdraw the substance. So there is work, school, and home failure because of the active substance use and substance seeking behavior. Interpersonal and social issues occur because of the substance use and the substance seeking behavior. Too much time to find the substance. That is like, I do not have time for my family, I do not have time for my work, but I spend so much of time to identify where that substance is being sold. Right? It is Gandhi Jayanti and all the task shops are closed, but still I find a way to get the substance. Right? And then hazardous use. So I know I have a drink and driving and I had an accident and my bone is broken. I've been undergoing surgeries, etc. and I'm coming out of it. I know after drinking, I'm forgetting things. I know after drinking, it is getting dangerous for my body. Despite that, I am using it. So use despite harm is called as hazardous use. Desire, craving. So after 6 o'clock, I have to drink. Right? I have the craving to drink. In that desire, nothing else comes in front. Right? Even if there is an important assignment at 6 o'clock, I'll go drink and then only I will think of it. right? Reinstatement of drinking. So I quit drinking. I put Sabarimala Mala and I quit drinking. On 30th day, I went to Sabarimala and I started drinking, and quickly I came to the old pattern. So I was drinking 4 quarters every day. I quit, I did not drink, and after 30 days, after 90 days, I started drinking. I did not take like 1 week, 10 days, starting from 1 quarter, 1.5, 90 ml, and then going. No, immediately I started reinstatement of the previous pattern of drinking. Immediately I went to 4 quarters a day. Right. All the other activities I have given up. I have stopped attending parties. I have stopped going to weddings. I have stopped going to my children's annual day functions. Nothing. I'm drinking all the time. Right. Withdrawal. Once I stop drinking or think of stopping drinking or even reduce the dosage of drinking, I get lot of symptoms. Withdrawal. I started with 90 ml. Now I am going to 2 quarters, 3 quarters, 4 quarters, and sometimes still not getting the high, that is called as tolerance. Harmful use, again, use despite harm. I'm drinking to such an extent that my liver functions are getting affected, and it exceeds the time. I go to the Tasmak shop trying to buy only 1 quarter, but I buy like 2 or 3 quarters. I go to the bar and I think I have to spend time only 1 hour here, but I spent the entire night drinking. So exceeding in time and usage. Right? So these are the dependence criteria. This I have given example as alcohol. This also applies to other substances. It also applies to behaviors. Imagine smartphone addiction, right? Or internet addiction, or whatever you want to think about. Again, here the same dependence criteria work. Instead of working, going to school, or taking care of the family, I am sitting on my phone gaming all day. I am not looking at my interpersonal issues. I am gaming all day. I am spending so much of time and money to find the particular game. Right? I am using it despite all the harm. I have eye strain, I have headache, I have problems, I have lost money in that game, but still I'm using it. I have that intense craving to game every day. I try to quit it, but I have reinstated my old gaming patterns. There are 24 hours in a day. I am gaming for 18 to 20 hours. If I stop, I have withdrawal symptoms. I get irritable. I get, anxious. I get palpitations. And I started with 1 hour a day, 2 hours a day. Now it is going for 20 hours a day, and I'm still not able to feel the high of gaming. Right? This is all the criteria that we can apply for behavioral addiction and substance use disorders. Right? Now coming to cannabis. So cannabis, the other terms can be commonly asked in both forensic and psychiatry. Hemp, ganja, bhang, charas, hashish, marijuana, weed. All of these are cannabis street names. The active ingredient is tetrahydrocannabinol, also called as THC. Sometimes when people take cannabis and have a bad experience, panic-like experience, that is called as bad trips, the colloquial language. Sometimes they get flashback phenomenon. It is seen in cannabis and LSD users. So even while they are not taking cannabis, they will have that flashback of whatever happened when they were inebriated with cannabis. Right? Sometimes it can induce psychosis. Most commonly, it causes amotivation syndrome. So cannabis users, they do not have the motivation to do anything, to wake up, to sit, to study, to eat, etc. A lot of people have amotivational syndrome. So when you are intoxicated with cannabis, there is euphoria, there is slowness of time, there is redness of eyes, conjunctivitis, increased appetite, what they call the munchies, that's how they call it, munchies, and delirium-like symptoms. Okay, in withdrawal, they get depressed, irritable, anxious, decreased appetite, amotivational syndrome, tremors, chills, pain and fever depending upon the patient. But mostly it does not have physical withdrawal symptoms. It is mostly psychological withdrawal. It is not like alcohol. Alcohol has physical withdrawal. There is the BP fluctuation, there is sweating, there is tremors, there is delirium, there is seizures. Whereas in cannabis, it is mostly psychological in nature. All of this can come in a mild extent. Okay. Coming to behavioral addiction, only two behavioral addictions are recognized in DSM and ICD, that is gaming disorder and gambling disorder. Gaming disorder and gambling disorder, right? Internet gaming disorder and gambling disorder, right? It is like substance but behavior. I told you, right, in the addiction criteria, how it can apply to both substance and also behavioral addictions. So a lot of behaviors can cause addiction: gambling, gaming, internet, social media, selfie addiction, cell phone, eating, TV, shopping, porn addiction, porn videos, etc. What happens is, in gambling especially, and in a lot of internet gaming disorders also, there is this variable reinforcement that happens. So there are types of reinforcements that we study in behavioral theory. So behavioral theory was a theory given by John Watson. How it is implemented is based on rewards and punishments. So when something is rewarded, the behavior gets reinforced. So for example, if I give a chocolate to a young kid after singing a rhyme, the kid will keep on singing the rhyme. That is rewards. If I punish for doing a behavior, the behavior will get reduced. So that is punishment. So that reinforcement with rewards and decrease based on punishment is what is happening in behaviors. That's what they say. So if a person works for a month and they get the salary at the end of the month, that is called as fixed reinforcement schedule. So in every fixed intervals, you get the reinforcement for your behavior, right? Whereas in marketing, in incentive-based jobs, so whenever you keep doing, you get more rewards. So that is kind of a variable reinforcement. The same variable reinforcement occurs very rapidly. So if I put 1 in my dice, I get 10 lakhs. If I put 2, I might lose 5 lakhs. And then if I take 6, then I might get 15 lakhs. So every moment I am variably getting reinforced. This time I might get, this time I might get, this time I might get. So in that way, I am getting hooked. That is seen in gambling. So variable reinforcement schedule occurs where there is unpredictable rewards and hence keep the person hooked, right? So in children, people with gaming disorders, they have delayed speech, sometimes attention deficit, behavioral problems, and suicide attempts are also reported. Okay. So what happens is, the reward pathway in any addiction gets hijacked. So usually the humans are social animals. So we get sitting in a class and studying, speaking to our friends, talking over phone, chatting with them, talking to other people. When they smile, when they, give an acknowledgement, when they give something rewarding, everything is rewards for us. If there is a Pongal, we feel happy to eat Pongal, to spend time with family. There is Diwali, if there is Christmas, if there is Ramzan, we have happiness from all of this. When all of this is getting hijacked, the entire reward pathway is getting hijacked by that one particular behavior. It could be substance use, it could be internet use, it could be gaming, whatever. Then that is called as addiction, right? Coming to smoking. So smoking cessation, again, very, very, very frequently asked question, right? Varenicline has been a repeated question. So for substitution therapy, you have nicotine replacement therapy. There are patches, gums, lozenges, spray, and inhaler. All 5 are nicotine replacement therapy. Chew and park method is used when there is a 15-minute gap between the gum and the acidic food or soda. For example, you are chewing nicotine gum, want to drink soda, you chew it and you park it for 15 minutes gap, and then you drink the soda. So this helps to increase the availability of nicotine and helps in replacement, right? Nicotine, amount of nicotine released from a lozenge is more than from a gum. Medications used are varenicline and bupropion. So these two have been part of a question in INI-CET. Okay. So varenicline is a partial alpha-4 beta-2 agonist. It acts on the nucleus accumbens of the reward pathway, and it has a black box warning for psychosis, right? Hence, it has to be used with caution. Bupropion is a norepinephrine and dopamine reuptake inhibitor, as an NDRI. It is actually used as an antidepressant because it has no sexual side effects, so hence it has to be a replacement for SSRIs and other antidepressants. Whereas it has a risk of seizure, right? Hence, it is contraindicated in head injury and seizure disorder patients, and it can worsen the eating disorder. Hence, it is contraindicated there. So, in nicotine, you should know what are the 5: nicotine patches, lozenges, gums, nicotine spray, nicotine inhaler. Nicotine inhaler actually replaces the hand-to-mouth ritual of smoking. Nicotine lozenges have better bioavailability than gums. When you're using gum, you have to use a chew and park method if you are going to take soda or other acidic beverages. Medications are varenicline and bupropion. Varenicline is a partial alpha-4 beta-2 agonist, and bupropion is an NDRI, right? Now coming to schizophrenia. The schizophrenia as a whole, again, it is an important question. So traditionally, if a questionnaire is a traditional person and is setting questions, they will first take a question from schizophrenia. Doesn't matter, it could be a simple question based on history, like who coined the term schizophrenia, or it could be treatment, or it could be a complicated psychopathology. So you should know everything about schizophrenia. So schizophrenia, the term means split. Phrenia means thoughts or mind, right? So this definition does not apply right now, but still that is how the term was coined. So Emil Kraepelin coined the term dementia precox, after which Eugene Bleuler coined the term schizophrenia. He gave the 4 A's of schizophrenia. What are the 4 A's of schizophrenia? Important question. Autism, where they live in their own fantasy world. Ambivalence, that they cannot decide. They'll stand at the edge of the seat and they'll not be able to decide whether to sit or stand. They'll stand at the edge of the door. They'll not be able to decide whether to come in or out. So they have ambivalence in making decisions, and they have an affective flattening. The face is having no emotional expression. The expression is flat or blunt, affective flattening. And the thought disorder that we studied, loosening of associations, the associations between different thought processes is lost. Hence, there is just words, right? There is no logical connection to it. Autism, ambivalence, affective flattening, and loosening of association. But the diagnosis of schizophrenia is based on the criteria from DSM-5. It has 5 symptoms: delusions, hallucinations, disorganized speech, disorganized behavior or catatonia, and negative symptoms. Of these, there should be at least 2 symptoms, of which one should be from the first 3. Right? So either delusions, hallucinations, disorganized speech should be there, and of the remaining, there should be 1 symptom. Right? For DSM-5, the criteria is 6 months. For ICD-11, if the acute symptoms are of 1 month, it can be diagnosed. Antipsychotics, there are 2 generations. First generation is also called as typical antipsychotics. Second generation is also called as atypical antipsychotics. So we prefer atypical antipsychotics to typical antipsychotics because of the extrapyramidal symptoms, whereas atypical antipsychotics cause a lot of weight gain and metabolic symptoms. Duration of treatment: for first episode, 1 to 2 years of treatment. For more than 2 episodes, 5 years to lifelong treatment should be given. Treatment-resistant schizophrenia, criteria for treatment-resistant schizophrenia is Keynes criteria, modified Keynes criteria, and at least which shows 2 different antipsychotics are given in an adequate dose for adequate period of time, and there is no response. Response is measured using brief psychiatry rating scale, BPRS scale, 45 score is not improving, and it is either 45 or above. The score is not decreasing, and the clinical global impression scale is more than 4. Right? The clinical global impairment is higher, and brief psychiatric rating scale scoring is also not going down, which means adequate dose at adequate duration is not having the adequate response. 2 different antipsychotics are used and still not responding, then that is called as treatment-resistant schizophrenia. For treatment-resistant schizophrenia, the drug of choice is clozapine. Okay. Next is catatonia. So catatonia is a syndrome on its own.